While there are many factors that affect workforce participation, where a decision is made not to work due to financial disincentives imposed by the tax and transfer system, then that, along with the longer-term capability costs of the decision not to work, that should be of great concern to policymakers. If the policy settings are not right, if incentives are misaligned, the tax and transfer system can deprive individuals of the opportunity to develop their capabilities. Perversely, it can even lock disadvantaged groups into intergenerational cycles of dependence. The tax review that I've been leading these past 18 months has been told many times, including by those who are themselves disabled, that the current system does not adequately recognise the desirability of some people with a disability participating in work, with their income support payment effectively contingent on them working little or not at all. That is one perspective. Understandably, however, not everybody sees adverse incentives as the problem. But my point is this: whether it's because of poor incentives in the tax and transfer system or whether it's something else entirely, it's hard to believe that an ever-increasing number of people dependent on income support is the best that we can do in this country. Thus, despite the difficulty of the task, reducing the distortions to participation and finding other ways of enhancing the opportunities for individuals to build the capabilities to lead the kind of life they value and that they have reason to value, that must remain an important goal of policy. And the budget provides the instruments for pursuing that goal. Another way that the budget can improve human capability is through health expenditure. In 71-72, Australian government expenditure on health was around 1.5% of GDP. By 75-76, it had risen to 3.5% of GDP. While health expenditure then fell to less than 2% in 82-83, it's increased steadily since then to now be more than 4% of gross domestic product. There are several factors behind this increase in public health expenditure. Most obviously, health spending tends to rise as the population ages. We tend to need more health services as we get older. In addition, technological developments mean that the range and the quality of health services available increases over time. And of course, income growth encourages a more than proportionate increase in the demand for health services. The most recent intergenerational report projected that Australian government health spending would grow to 7.3% of GDP in 2046-47. Updated projections will be presented in the next intergenerational report, which the government has committed to release prior to the 2010-11 budget. Clearly, health expenditure will continue to be a significant source of fiscal pressure. Meeting the community's demands for more and for better quality health services within a restricted fiscal envelope will prove increasingly challenging for governments. It will require difficult choices, difficult trade-offs to be made about the level and the quality of health services we consume, who pays for them, and how they pay for them. As the fiscal pressures of an ageing population mount, governments will be judged by their ability to deliver better quality public services within ever tighter budget constraints. Unfortunately, the ability of the community to be able to make well-informed judgments is limited. It's limited by the fact that we are well short of having sufficiently good information about the nature of government's taxation and expenditure programs and the relationship they bear to outcomes. There are several reasons for this. It's often difficult to measure the quantity and the quality of public sector services. ABS measures of the value of the output of the health and education services sectors are based on the cost of production, with the split between quantity and price largely based on relevant wage cost indices. This means, for example, that if it takes one doctor twice as long to perform the same medical procedure to the same quality as another, then that first doctor is calculated to have produced precisely twice as much. As a report by the Stiglitz-Sen Commission on the Measurement of Economic Performance and Social Progress notes, and I'll quote, "An immediate consequence of using inputs to measure these services is that productivity change for government-provided services is ignored, because outputs are taken to move at the same rhythm as inputs. It follows that if there is positive productivity growth in the public sector, our measures underestimate growth. The quote concludes. Similarly, of course, if there's negative productivity growth in the public sector, our measures would overestimate growth. So improving the measurement of non-market service sectors of the economy is one of the Stiglitz-Sen Commission's priority recommendations. It's also difficult to measure the outcomes in areas such as health. For example, life expectancy is the most broadly available and therefore, I would suggest, it's the most commonly used indicator of health outcomes, but it's clearly an incomplete measure of the health of the population. Life expectancy measures mortality only. It doesn't provide any information on the quality of life or the burden of chronic disease. Ideally, we want an indicator that includes information on both mortality and morbidity. However, as noted by the Stiglitz-Sen Commission, and again I'll quote, although several combined indices of people's health exist, none currently commands universal agreement. Further, they all inevitably rest on ethical judgments that are controversial and on weights for various medical conditions whose legitimacy is not always clear, unquote. Even if we could solve these dilemmas, we'd still be left with a third, and that is the difficulty in identifying the impact of changes in government expenditure on outcomes that are also heavily influenced by individual decisions and by individual behaviour. The lack of evidence of a clear relationship between increased expenditure and better outcomes is not to say that more expenditure will not improve outcomes. Yet it is probably safe to say that micro-level decisions on where and on what we spend money are just as important as the aggregates. It's also clear that good program design and delivery are important to getting value for the public's money. Finally, I'd like to highlight briefly another important way in which fiscal policy and the budget can and indeed has been used to improve well-being. There is, I think, a solid, though not uncontested, consensus that economic reforms of the past quarter of a century have played an important role in the improved performance and resilience of the Australian economy. It's less widely appreciated how the budget has often been used as a tool to help smooth the implementation of these reforms, facilitating the often difficult adjustments that accompany structural reforms. A recent OECD study on the political economy of reform commented that, and again I'll quote, one of the most robust findings to emerge from recent econometric work on the political economy of structural reform is that sound public finances tend to be associated with more reform. To put this somewhat retrospectively, of course, into our well-being framework, structural reforms have often involved increasing risk to some parts of the community in order to benefit Australian society in some aggregate sense.